Good afternoon. My name is Megan Bretz, and I direct our neurologic residency program and oversee some implementation efforts with our stroke population in inpatient rehab. The project I'm sharing today has significant contributions from our first resident graduate, Dr. Hannah Lamar, with support provided by our academic collaborators, Drs. Henderson, Moore, and Hornby. Additionally, I am a treating clinician, an adjunct faculty member at the University of Evansville, and a consultant for the Institute of Knowledge Translation. Some products are featured in this presentation, but I do not have any relevant interest in them. Ascension St. Vincent Evansville is a large community-based hospital system that is located in southwestern Indiana. We have a small 24-bed CARF-accredited inpatient rehab facility that manages about 400 patients a year, of which approximately 20% of these admissions are post-stroke. We are proud to offer the first accredited neurologic residency program for physical therapists in Indiana, and the work I'm presenting today was residency initiated in this facility with our stroke population. The first step in any knowledge translation project is a thorough evaluation of the literature to understand current best practice. And current evidence states that maximizing the amount and the intensity of walking practice while allowing and even inducing errors in movement is critical to optimize the recovery of walking function after stroke, which is a primary goal of our patients. This has clear tiebacks to the principles of neuroplasticity, exercise physiology, and motor learning, with other inpatient organizations successfully implementing this evidence. So how does our practice align with this current evidence? So the answer in 2019 was sort of. We'd worked really hard over the years to implement the evidence, and we'd come a long way, but there was still quite a bit of practice variability within our team. Clinicians continued to devote quite a bit of treatment time to addressing impairments and isolation and non-walking activities, and for this reason, not nearly enough time was being allotted to walking practice in individuals that had primary goals to improve in this area. Sometimes heart rate was monitored during sessions, but many times it was not. With heart rate as a primary indicator of intensity, this left us a little in the dark about how intensely our patients were working during sessions. Our resident needed an implementation project, and this observation led to our first question. What is our current practice around continuous heart rate monitoring during PT sessions after stroke? To answer it, we dove into charts from patients who had discharged from our unit post-stroke between the months of May and September of 2019. This time frame was selected because it was prior to our resident transitioning to the inpatient rehab unit, and we felt it was a more accurate depiction of usual care. Not surprisingly, only 26.2% of treatment sessions were continuously monitored for heart rate response, which is consistent with observational studies that suggest monitoring vitals really isn't something most physical therapists do as part of routine practice, despite the fact that data suggests our outcomes may be better if we did. So not great in this area. Our audit results were brought to Dr. Moore, who's an expert in knowledge translation, to help guide an implementation project. We clearly were lacking in both intensity monitoring and walking prioritization, but to make the project manageable, we started small with a single goal. Can we increase clinician compliance with continuous heart rate monitoring during PT sessions post-stroke? And if successful, how would this practice change impact functional outcomes in our patients? The May to September audits became our usual care group. In September, we invested in enough heart rate monitors so every clinician could use one, either paired with the 2 departmental iPods or their own devices. In October, a resident rotated to the inpatient rehab unit right after she and another rehab clinician had attended a high-intensity training course. After meeting with Dr. Moore in November, we introduced the project to our team through a survey that had a threefold purpose. Number 1, to provide the audit results on our current heart rate monitoring practices. Number 2, to identify the most common barriers to heart rate monitoring during sessions. And number 3, to gain team input on a realistic goal around improving heart rate monitoring during sessions. We pulled the team together in December, and we collectively set a project goal that 65% of all sessions post-stroke will be continuously monitored for heart rate response. The team felt the goal was realistic, assuming the identified barriers of not enough equipment, time, and knowledge were all addressed. So right after the meeting, we started to do just that. We purchased enough iPods for each clinician, downloaded the heart rate monitoring app, paired the monitors to the iPods, and organized them in caddies for easy access. Heart rate calculators were loaded onto computers for quick calculation of targets. Documentation shortcuts were created for consistent and efficient recording of heart rate data during sessions. Education around heart rate monitoring itself was provided, but so was information on how to deliver an intensive walking prioritized session. And resources created by our didactic residency partner, the Institute for Knowledge Translation, were also shared. From January to December, all charts were routed for heart rate data and outcome measure changes, and written feedback was provided to the clinical team monthly. In mid-April, we added step monitoring. We placed these ankle-based accelerometers on our patients with daily targets based on mobility and suggestions from other implementing teams. Stepping data was added to the report, and this report began to be generated weekly. In July, the heart rate monitoring project was turned into a formal performance improvement project with a new goal based on our performance that 80% of all sessions will be continuously monitored for heart rate response. In October, we initiated case reviews in every 5th patient post-stroke that discharged from the unit. This deeper dive included heart rate data, stepping data, and functional outcomes, and this additional summary was shared with the team. Based on our monthly compliance audits, we decided the project was complete in December, and we identified the final patients of the year, those that discharged between June and December of 2020, as the implementation group. So how did we do? As depicted by the blue line, our heart rate monitoring compliance skyrocketed over the year. Not only was heart rate better monitored, but it appeared that sessions were trending towards achieving higher intensities, as measured by reaching either 75% heart rate max or a reported 15 on the RPE scale, as depicted by the orange line. Each PT session was further determined to have either prioritized walking interventions or not. Similar to our heart rate outcomes, as depicted by the gray line, it appears that sessions overall were trending towards improved walking prioritization. If we overlap our timeline on this data, we can see some relationships between the knowledge translation strategies applied and our outcomes. In September and again in December, we beefed up our heart rate monitoring equipment, and we see peak in our outcomes at these times. Also in December, we brought the team together to introduce the project and gain input. The December peak was followed by a January crash. Monthly audit and feedback started at the end of January, and we see a big climb in outcomes and holding from that point. COVID hit us around March in Evansville. This tanked our admissions and rattled the team, and we wouldn't have been surprised to see this reflected in poor performance, but we kept pushing the project forward. We added step monitoring in mid-April. Beginning in May, audit and feedback on heart rate and step counts was now provided weekly, not monthly. In July, the project was turned into a formal performance improvement project. We continued to climb in outcomes, and now with intensity trending up. So yes, we were able to increase clinician compliance with continuous heart rate monitoring with responses reaching greater overall intensity. But did it result in anything meaningful? In order to answer that question, we dove in a little deeper into the implementation and usual care groups. To analyze our data, we first tested for normality and found that none of the variables were normally distributed. As a result, we used non-parametric tests, and the results were displayed as medians and entire quartile ranges. Nominal data were tested using chi-square tests, and the alpha was set to 0.05 for all analyses. At admission to the unit, there were no between-group differences in demographics, baseline assessments, or training characteristics with p-values ranging from 0.19 to 0.70. But heart rate monitoring compliance, session intensity, and walking prioritization were all different between the two groups. Heart rate monitoring compliance increased from 26.2% of sessions during usual care to 92.3% of sessions in the implementation group. 15.5% of all eligible sessions reached the targeted heart rate or RPE zone during usual care, which increased to 48.5% in the implementation group. Finally, across all sessions in usual care, only 61% of sessions prioritized walking, in comparison to 84% of sessions in the implementation group. All between-group differences were found to be statistically significant, which is indicated by the bar and asterisks. Pictured on this slide are the change scores in each of the core outcome measures. In comparison to the usual care group, change scores in walking speed per the 10-meter walk test, walking endurance per the 6-minute walk test, and standing balance per the Berg Balance Scale were all significantly better in the implementation group. Of the 6 relevant PT-scored quality indicators, which is part of the inpatient rehab mandated patient assessment instrument, which informs lengths of stay, drives reimbursement for services, and is available for public viewing, the change scores were all better in favor of the implementation group in the areas of transfers, walking, and stair negotiation, with 5 of 6 between group differences found to be statistically significant. In fact, 90% of individuals in the implementation group discharged walking at steady and assist or better, in comparison to only 66% in the usual care group, which was also found to be statistically significant. With walking function as a primary indicator of discharge destination in inpatient rehab, this is pretty important. So yes, it does appear this practice change was associated with improved patient outcomes. To wrap this up, implementation of heart rate monitoring and patient achievement of higher intensity targets during sessions was possible. Although not an original project intent, we did observe a practice shift towards walking prioritization during sessions, which likely contributed to our outcomes. These practice changes were associated with improvements in walking, which is expected, but the improvements in the less practiced non-walking activities and impairments, like transfers and balance, is interesting. A common concern that many clinicians have with prioritizing walking during sessions is the potential disregard of these other important areas. Not only were our patients not penalized for less specific practice of these skills, they actually improved even more in these areas. Facilitators to our success include leadership support, targeted addressing of barriers, clinician involvement in the project itself, including goal setting around it, audit and feedback on performance, and just a general commitment to delivering the best care to optimize outcomes. In closing, we set out to do one thing: get clinicians monitoring heart rate, but it snowballed into a lot of other KT strategies that without a doubt impacted our outcomes. I don't think we will ever be able to tease out which intervention or which combination of interventions was pivotal to our efforts, but something worked, and it appeared that all this was spurred by our heart rate monitoring initiative. For other organizations looking to implement an intensive walking prioritized treatment approach to stroke rehab, maybe this is a good place to start. None of this would have been possible without our clinical team. We appreciate them, and we appreciate you for listening to our story. Thank you.